Thanks very much for being part of this. We appreciate you taking the time to listen in and to our second really webinar that we've done, Neurology Department Chairs and Academic Business Administrators, Webinar 2. And really, it's all about trying to share some best practices, particularly during this difficult time with COVID-19. If I can get the next slide. So I'm happy to be here, and I'm really delighted that I have a number of New York City Department Chairs with us. As you know, New York City has been one of the hardest places hit in the United States. So with us today are Steve Galletta, Chair from NYU. We also have Richard Mayu, Department Chair from Columbia University, and Barber Vickery, Department Chair at Mount Sinai. And then Larry Goldstein, who's Department Chair at the University of Kentucky, and David Greer, Department Chair from Boston University, who was on our last webinar, as you know, are also here for the second part of the broadcast. Next slide, please. So basically what we're going to try to cover, I'm just going to give a very brief update, and then we're going to hear directly from 3 department chairs that are in New York City, and I appreciate them taking the time to be part of this and sharing their sense of what they had to do as a department to deal with the surge that occurred in New York City. And then we're going to hear a little bit about some other approaches to intradepartmental communications during a pandemic. Next slide, please. So as you know, this is part of our academic neurology initiative. We've done a number of things. Our Chair Summit 3, as you know, was canceled or postponed because of the pandemic. But there are many things that we're trying to do to help support many of the academic members that we have as part of the AAN. We're continuing to move ahead in addressing needs for these constituents. We had a webinar 2 weeks ago that was very successful. We have a funds flow paper that's out now that Andy Josephson, first author in, and appeared in Neurology. Please take a look at that. This may be helpful information to getting support for neurology departments. We're also working with funding the educational mission work group, and David Greer is helping lead that, and that writing group is hard at work to get a paper going. And then Barbara Vickery has been leading an important paper regarding service lines that is working on some other interview questions that have been beta tested and will start up again in May. Next slide, please. So there's also many resources out there for actually academic members as well as our practicing members. And it's the COVID-19 Neurology Resource Center in the AAN. We've tried to centralize as much as we could all of the resources. As you know, there's tons of help there for particularly virtual neurology and telemedicine. Next slide, please. So you can see things there. Everything is collected in one place for articles, things regarding practice, an interview with Sanjay Gupta, things for patients, education, research. Advocacy has been big. We've been advocating, as you know, for continued payment for virtual neurology that will be critical to continuing work during the pandemic and other resources. Next slide. I also want to remind you that these webinars are one way of communicating and getting best practices shared, but sometimes we can't always get to all the questions, and I wish we had more time for active, interactive engagement. We do have Synapse. That's a way that you can post other questions and get collective input on different difficult issues. So please use Synapse. And also, we're looking for other ideas and other topics you can use during the chat feature during this call to indicate future topic suggestions if you find this helpful, or emailing Sue Rodmeyer or Claire at the AAN. Next slide, please. And remember, this is a webinar. Most of us have been doing Zooms all day, and the regular Zooms have a lot of pictures. We couldn't have everybody, unfortunately, speaking at the same time. So with the webinar, there are ways. Put your questions, write them down using the Q&A bar that's there, and then the chat function if indeed you have any technical difficulties. We'll be monitoring the Q&A, and we'll do the best we can to hit some of those questions. So I should stop talking so we can get to our program. Next slide. So the first part is really hearing directly from 3 key leaders in New York City. We're going to lead off with Richard Mayu, who, as you know, was an author on a paper in neurology about just this topic. Head to Steve Galletta, and then hear from Barber Vickery. So without further ado, next slide, I'd like to introduce Richard Mayu, who's chairman at Columbia University, New York Presbyterian Hospital. Richard, thanks for being here. Don't forget to unmute, Richard.
Thank you for inviting me, and it's a pleasure to be here. And it's a pleasure to be talking about something that's starting to look like it might be plateauing a bit. Next slide. So this hit us pretty hard, and we had to make a lot of rapid changes. So, and being someone who was trained in medicine over 40 years ago, it was a little bit unique to me and a little bit difficult. So we immediately started multidisciplinary meetings with our staff to create a plan to cope with this process. We started a webcast system with twice weekly evening calls for the faculty. In fact, I just had one before coming on using Zoom. All of our laboratories had to be closed, so we had to ramp down very quickly. Observational studies were shifted to telecommunications. All clinical trials, unless it was something that was required for the patient's safety, were paused. We had been dabbling in telemedicine, and now I'd say we're in full speed ahead in telemedicine, as I'm sure most of you are, and we're coordinating this with radiology for imaging. We have a division that has a significant number of neuropsychologists. Some of them have psychotherapy training, and they provided support for people that just needed to unload or talk about the experience they were having. Next slide. The inpatient service, all elective admissions were paused for both adult and pediatrics. All patients were screened for symptoms and eventually tested for COVID-19. One section of our neurology inpatient service became a COVID unit for COVID positive patients, and that was managed by both neurology and internal medicine, and I'll explain that shortly. Neurology residents, fellows, and faculty were organized into a deployment workforce. Some individuals were redeployed to other services, but not many, because we had such a large footprint in terms of managing patients with this condition. We were all trained to don and doff protective equipment, and that was required for all. Next. The consult service was one of our biggest challenges. We transitioned to something I call curbside consults where possible. With the emergency room, we reserved face-to-face consultations, but really letting the ED doctor tell us. So when they would call us and say, you know, we'd like you to see the patient, we would ask, do you want us to see the patient face-to-face? And if they said yes, then we were provided with full PPE and N95 masks. All of the stroke things like tissue, you know, TPA, thrombectomy, intracranial hemorrhage, all the acute emergencies, we worked with the ED and the nursing staff so that we could handle those as quickly as possible because this is a normal flow. In addition, we had consults that had vascular problems in relation to COVID-19. Next. The neurointensive care started off as a non-COVID ICU because they moved all the patients from all the other intensive cares into our intensive care, which is one of the largest ones in the medical center. And that shortly became a COVID center. We tended to get more patients with neurological problems in our ICU compared to the others, but we also had just ordinary patients who needed intensive care. The hospital, and along with recommendations from the chairs, decided that all intubation should be done by anesthesia so there wouldn't be mistakes and you would limit the amount of aerosol virus. All central lines were put in by surgeons or surgery staff. We had a major role in assessing prognosis in comatose patients and assisting in the assessment of brain death. And so we had to work with our colleagues in medicine to teach them how to do coma type exams. Next. This schematic is just showing you, and you can see it in the paper and how we transitioned. So we created these teams, and each team had a medicine person associated with it to help us. And we really shifted into a neurocritical team a neuroconsult team, and an inpatient team. We did the same thing for pediatric neurology, but there were far fewer patients with pediatric problems. Next slide. I should point out that we had to close our EMUs, both our adult and pediatric EMU, both of which were very active, but we still were monitoring many patients who were in comatose state throughout the hospital. For education, all the clerkships were suspended and moved to a virtual curriculum. The shelf exam is planned for a remote examination. We continued the resident and fellowship noontime lectures using video conferencing. We provided counseling, as I said before. Senior faculty have all taken turns purchasing dinner each night for the residents who are staying late. And PPE, scrubs, and lunch were provided throughout. Next. This process was led by these folks here, especially our chief resident, Jenna Waldman, and Jan Clausen and Sachin were very helpful in setting up our ICUs. Josh Wiley took over the stroke consult service. Our administrator was involved, and Kieran Thaker was an outstanding contributor to helping us organize this. So that's how we did it in New York City.
And are still doing it.
Still doing it.
Okay, yeah. Next slide. So again, if you have questions, please write them into the Q&A box. We're going to come back to everyone towards the end. We're going to now turn a little bit more to a different department in New York City, NYU, and hear a little bit about lessons learned from the COVID-19 epicenter. And I think we're going to focus a little bit on psychosocial effects in the department. So Steve Galetta, if you can.
Thanks very much, Ralph. And I want to thank the Academy and our colleagues around the world who have supported us through this. The topic is lessons learned, and I'm sure I'm going to learn a lot more than I have in the last 5 or 6 weeks. But I wanted to focus in on some of the real hot spots for us. Next slide, please. For a variety of reasons, PPE was a problem in the city and across the country, and it probably reflects the acuteness and the intensity of the onset of this crisis. There were also political factors that were operative. And the other reason is that the suppliers were largely out of the United States. We have 5 hospitals in our system, and it would vary what was short at those hospitals. We have a large public hospital and a large academic hospital. Early on, we had problems with masks, and now gowns are in short supply. So what we did, and is kind of remarkable, is that if you email your faculty and your residents, there are people that have access to PPE. And what we found was that the medical students in New York were collecting PPE from various corporations. So on this past Monday, for instance, we were short gowns. And I sent out an email at 1 o'clock in the afternoon to the faculty and the house staff, and I got numerous responses. The medical students, we were told, had PPE. We called them up. They gave us 120 gowns on the spot. In fact, colleagues in China also are sending boxes of gowns with connections with our faculty here. And then finally, we realized that there were 80 gowns, for instance, sitting in the epilepsy division that could be harnessed. So by 5 o'clock on this past Monday, we were able to deliver to our residents 200 gowns. And it just is important to realize that people on your staff have these connections. And if somebody offers you stuff, you take it. Because when you could deliver these masks or these gowns to your house staff, they feel like you've supported them. Invaluable. And finally, 3D printing can be helpful. The surgeons are printing masks, they're printing other types of PPE, and I think it's another great source. Next slide. But what I really want to focus on, which I think is going to be important in the short term as well as the long term, particularly as our institutions are under great financial duress, are the psychosocial aspects. There are a lot of people that are fearful. Some are actually afraid to come out of their houses right now. There's tremendous amount of anxiety, and it's exacerbated by the loneliness of it all. Because when they leave the hospital, they can't come out and socialize, and we can't necessarily socialize with them too well. So our residents who love to text us now want to Zoom us. And in fact, we meet with them by Zoom twice a week, where we have a debriefing session, where we tell them about what's going on, and they tell us what's going on and how we can help them. And in fact, that's how it happened this past Monday. They said we're short gowns at between 12 and 1 o'clock on Monday, and at 1 o'clock we could go into action to get them what they need. We have counseling sessions with them led by psychiatry, and they almost all show up to it, and it's very, very, very traumatic for them. They've seen a lot of death, and the death can be very, very sudden. They could be talking to you, and then the next minute, unfortunately, and they're young people, have died, and so they're incredibly upset. Food is love. As Richard said, we feed the front lines, and that is because people got to get out of their PPE in order to eat. And there's so much going on that we send food, both lunch and dinner, and the department raised amongst the faculty $14,000 to support this. And is this, again, another way to tell your residents, your nurses, your APPs, various other people that you're caring about them and you're doing what you can do. Because the reality is that the residents and the fellows are the most valuable people to medicine in this process. The attendings tried to be hero types, but it was really our residents that could do the job. And then every night I write a note to the faculty, the residents, summarizing the day, telling the data that we're receiving. There's a comedy section. One of those comedy photos is right up there where you see a Zoom meeting with audio only, and the dog doesn't look like it's groomed. And then, of course, when there's video, everybody's groomed up. And then there's the music video of the day. And I give credit to the people that send me, you know, inspirational musical videos. And people really look forward to this. Next slide. Next slide. Now, so we in general medicine created a handbook, a survival handbook, and it's incredible. And I shared it with Ralph, and happy to have it shared with all of you. And I think this is more for the long haul. And that is, it's a handbook that gives URLs for relaxing websites, meditation websites, webinars for managing anxiety and stress. It lists all the daily groups, therapy sessions led by psychiatry, there are 30 of them. Also provides for individual psychiatry hotlines for house staff or hotlines for meditation and relaxation. And what's really cool about it is that there are websites for exercise. Where can you get free food? Like Starbucks will give healthcare workers free food, and so will Krispy Kreme. You got to exercise it off. But there are culture and arts sections, recorded Broadway shows, virtual dance parties. And I can tell you that virtual happy hours we have amongst divisions in our department, as well as the residents. We have every Thursday night through June, we have with the residents a happy hour. We had one last night, 15 residents show up. It's a great time. And again, they don't want to text you anymore. They want to Zoom you. And so it's really pretty good. They want to actually see your face. Next slide. And I want to end with something that is like atom smashing. It is a good thing. And that is the dramatic advances in telemedicine that have happened to us, including this week. And I realize that this is institution dependent, but some form of it should come your way. And one of the major advances is Cisco Jabber. That is that a clinician from their phone can enter a patient's room in the hospital and examine them via a bolted iPad. And that's down on the left-hand corner. That's my phone. I'm in my office and I'm with an attending who's examining a COVID patient in the hospital who's got Guillain-Barré. I could see the exam. I could direct the nurse, if it's only the nurse in the background that's there, to do the examination. This is going to forever change education, and it will put potentially all of your faculty available to the residents, will change education, and it's preserved PPE. Our residents can be in a workroom and be with the attending, watching things go live. The other dramatic advance is down on the right-hand corner, and this is Haiku to Haiku. This is the Epic mobile application. And what I'm showing here is that a resident could be with the patient in a separate location, an attending could be on that line in a separate location with that patient. And so this is a way that we're going to do our clinical assessment exams required for graduation. We can do them virtually. And another amazing application is, I'm demonstrating right here, is clinician video chat. We all logged into the same patient. There's 3 attendings here. Dr. Weinberg on top, Dr. Fu on the bottom, and I'm in the right upper hand corner, and we can chat about a case all from different locations. We could do family meetings this way. You can also be with, again, the resident who could show you the findings. So really, the advances in technology will change forever the way we practice, and these are just 2 examples. So I want to wish you all well. I'm happy to help in any way I can.
Thanks, Steve. And you're so right about the whole thing with what virtual, from FaceTime to Haiku to Cisco Jabber has done, and will now change, I think, the way we conduct neurology and education moving forward. Next slide, please. So we also have Barber Vickery with us, and we don't have a video for her or a camera set up at the moment, but she's with us in voice. And I'd like Barber to say a few words and any other words of advice from her as chair at Mount Sinai in New York. Barber, can you hear us?
I can. Can you hear me?
Yep.
Great.
All right.
Thank you, and I would echo a lot of what you've heard so far. Just to give a little context, Sinai system, we have a neurologist at 6 hospitals in 3 boroughs, a medical school, of course, and 2 residency programs. And what you've heard is that all of us have had to be extremely nimble. For example, over a 2 to 3 week period, literally pivoting to entirely virtual outpatient setting and training our clinicians and staff and our patients on how to pivot to that. And at the same time, figure out on the inpatient side, and I totally agree about the technology. We use an InTouch system that we were rolling out to preserve PPE and to be able to do some virtual inpatient consultation in different contexts. And at the same time, in our system, we had a model in which faculty were deployed. So we have about 25 faculty neurologists who were deployed to medicine teams to partner with the medicine teams in taking care of COVID patients. Also 10 fellows. So, and they were working under the supervision of hospitalists, but we had about 2,000 COVID positive patients across our hospital system at the peak, which thankfully was a few days ago, and over 400 in the ICUs. So there was a tremendous deployment of faculty from other departments, and neurology did that, and very positive feedback from our faculty because they were given training and had the hospitalist backup on those medicine teams. But I think regardless, for every any situation, it's really going to depend on how your school and health system also are driving what the needs are and how they're going to meet it. Just want to mention that there was also, I'm sure Steve and Richard know this, the ACGME had an emergency declaration that allowed us to deploy fellows and residents to other services for the last here, I guess it's in 30-day periods, but we're about to enter our second 30-day period. And again, I agree, it's been tremendous across faculty and trainees, for the most part, how people have just really felt like this is why they became doctors, was to contribute in this way. So I just want to offer a couple of reflections. One is I think, and again, I think you've heard this, you have to be extremely nimble, because you're both very rapidly addressing the current situation and mandates that are coming externally, whether it's from the state or from your health system or your school. And at the same time, we're all trying to anticipate what's next. And it's literally changing from day to day. Here in New York, as the curve was going up and the surge was increasing, nobody knew how high it was going to go. There were different models, and fortunately, it didn't go as high as was anticipated, but it does mean you're then adapting to the next phase, and already there's plans to how do we reopen our practices and what will that look like, and it's not going to look like it did right beforehand, right? It's going to be different. So you have to be really nimble. I would say another reflection is there's a very intense and acute blend of dealing with people you've been dealing with in your health system and in your professional activities, but now it's all it's happening in a very heightened time frame and obviously around a very intense issue. So you're interacting with your staff, faculty, trainees, your peers, other chairs, and the leadership from the health system and the school in a daily basis, or certainly multiple times a week, as we're all focused on trying to address the acute surge with the COVID patients and then anticipate now where we're going next. A third reflection I'd have, and I really agree again with both of the other chairs, is it's clear teleneurology is here to stay. It has to stay. For one thing, as we reopen, we're not going to be able to practice in the same way in terms of at least until there's a vaccine, in terms of waiting rooms having lots of patients, or being able to just move people through exam rooms without stopping and cleaning them and checking their temperature and checking the patient's temperatures and so forth. So there's going to be some real changes for a while in the practice, and it's just got to be that we could continue a substantial amount of virtual care. And I think I would just put in a plug to the Academy that we're going to need to, a lot of restrictions have been lifted and a lot more of great new codes are available now for care that isn't even, video. I mean, there's now codes for providing services through patient portals, short phone calls, and a whole variety of other things. But they're going to really need to release neurologists from all the examination requirements, or we're going to be really disadvantaged financially down the line, because you can't, at least now, if you're trying to meet all the bullets for higher level E&M services, it's not really possible to do. I would say that we already had a team working on teleneurology for about 8 months. And like you heard, we all went into super drive, it just was amazing. But we were really grateful that we already had, a coder, a clinical informaticist, really a whole working group that had been moving. We had about a dozen faculty who'd had experience with 150 or so video visits, and now it's probably been 1,000 in the last 3 weeks, and many more faculty on board doing them. But we were grateful to have been trying to anticipate that. So I would say as much as possible, wherever you are in this, be planning for that because you really want that expertise. A fifth reflection I have here is you want to be joined at the hip with your administrator. There's just no way that isn't going to be the case. There's a lot of management around staff and faculty deployments. And obviously, this is a major disruption to the financing of any healthcare system. And in hospitals in New York City, we're asked to stop doing all their elective surgeries and so forth. And of course, we did that because we wanted to save lives with these patients. But it's a big machinery to stop in such a way, and then to try to restart with all the restrictions that are going to be in place because of the infection prevention aspects. And so I think that, you know, again, there's a lot of unknowns ahead, but what's certain is that you have to be both able to react quickly to what's happening externally, and also just constantly thinking ahead, thinking, okay, how are we going to plan the reopening of our practice? How are we going to get more patients comfortable with virtual visits, and all the other things that we're trying to envision about what the next year is going to look like. And I have to say that I'm not originally from New York, but this has been really remarkable being in New York City at 7 o'clock every night. You can hear it all across the city. People are out on their rooftops and banging bells and yelling at the top of their lungs in support of all the healthcare workers, and it's really quite inspiring.
Thank you, Barbara, for those reflections. And you know, the virtual neurology and the telemedicine is critical. It's something that we, you know, AAN had been advocating for, and now it is going into hyperdrive. And you know that the AAN continues to advocate for continuing the payments that are being made now for teleneurology. That's going to be critical as we move this forward, since this pandemic and COVID-19 is going to be with us for a little while. So again, if you have questions, please put them in the Q&A. There are a couple. I want to hold them and here to go to the next section that we're dealing with, which are from two other department chairs. One who's actually in the thick of things now in Boston, David Greer, who's chair at Boston University, and then Larry Goldstein, who's chair at the University of Kentucky. And both of them are going to talk a little bit different about some administrative issues and intradepartmental communications during a pandemic. Next slide. And go ahead.
Great. Thanks, Ralph. You think this could even be retitled things that I've learned that I've done really, really wrong along the way. There are a lot of ways to do communication with your department and multiple media. People have talked about doing Zoom meetings, but people want other kinds of communication also. And the departments really need the communication because, as with everything, I think in life, the unknown is typically worse than the known. And people's imaginations will go completely wild. They'll look at whatever statistic that they want from different websites, and you just really need to give them the best data that you can and what I'd call reel them in. Remember that your department consists of a lot of different kinds of people, and understanding who you're communicating to and when is very important. There are a lot of different either small groups or large groups. I send out a department-wide email every Friday. It sounds like Steve is doing it even more frequently than that, which is fantastic. You can meet with your division chiefs weekly. You can talk with your clinical faculty alone, the residents alone. There's a lot of different times that you are communicating with people, and you have to be careful with every one of them because you cannot control how people will receive your communications. Whatever light that they are in, just like in the rest of life, if they're in a bad mood or they've had a rough day, they're going to take it in a certain light, and you have to kind of accept that. You're not going to please everybody every time. I would recommend giving your communications a lot of thought beforehand. recognizing that you're always using a megaphone. It's kind of like if you're the president, everybody's listening to every single word that you're saying and recording it. Next slide, please. So I think this is important to remain consistent with your personal style. You don't need to become somebody else. You've usually already got a relationship with your department, and you've kind of developed an identity together. You've developed a culture. Stick with that. I think if you try to go outside of your comfort zone, you're going to make some mistakes. There is no one size fits all. You don't need to be a hero. You just need to lead your department, and they need to see you in that role. They also need to know that you're thinking of them. Remember that it's okay to deliver bad news. In fact, if you don't, people will criticize you for hiding something, being deceptive, not being completely transparent, or even being cowardly. Very importantly, keep your message consistent with the hospital and the medical school. The hospital, especially at this time, doesn't want you going rogue and telling very different information. Hopefully you have a good relationship with your hospital and you're giving the same statistics and the same messages. I have definitely pushed the hospital on a number of issues. I've done so carefully because I know that they get it from all angles. But as a chair, I think we have a responsibility to our constituents to advocate for them. And the hospital may not know exactly what the needs are. And so it's okay for your people to know what you're advocating for on their behalf. Even if you lose, you go down swinging. And I think people really appreciate the effort. Next slide, please. Very important to measure your effectiveness and learn from your mistakes and recalibrate. You're not going to get it right the first time. You're probably not going to get it right the second time. Try to get honest and direct feedback from multiple sources, including people that might not be your biggest fans. You want to hear from the people who are going to give you the most constructive criticism, and take it standing up. Don't get defensive about it. Embrace it and realize that they're there to help you. I sent out a survey to my department after the first, I would say, failed emails to say, what do you want to hear and how do you want to hear it, in what kind of tone, and how often do you want to hear from me? And I think that made people feel empowered that they could actually give me some instruction as to what they would like. And you can change your message according to the stage in the crisis. If you're in the build-up mode, it's very different from when you're at your peak or your plateau. Next slide, please. What we've done is started compartmentalizing our department-wide emails so people can actually pick and choose what they want to go to. We haven't named it this, but I have what's called the touchy-feely section. Some people do not want to hear about touchy-feely issues. And I say, don't go in this section if you don't want to read this. Some people are just all business right now, and that's totally fine. A potential structure that we use with our weekly emails is we give major updates and data to support it. We talk about standard issues, which I list there. Very important to give out shout outs, and different ones every week. If you can include pictures of people in action, they love that. They want to be recognized for their hard work. You know, people that go out of their way to help other people, make sure you recognize them. We send out, just like Steve said, inspirational articles, music, a humor corner, and words of encouragement. And we usually end with a quote of the week. And I've been quoting a lot of Abraham Lincoln and Martin Luther King to people. And I think that that really resonates with them in times like this. Using the Zoom to keep in touch with your residents, I totally agree with what Steve Galetta said. I used to do an outing called Beers with Greer, and now we do virtual Beers with Greer with the residents periodically to make sure that they stay connected with their chair. So you'll want to call it something else that rhymes with whatever alcoholic beverage of your choice, but I strongly recommend that too. Next slide, I think we turn it over to Larry.
Larry, can you hear us from the University of Kentucky in Lexington? Larry Goldstein, go ahead.
Yeah, I absolutely agree with absolutely every point that was made. Messaging, though, is absolutely critical. articulating the message, articulating that you're supporting your people, and being very clear about what the message is and what the information is, and being absolutely truthful and absolutely transparent at all times is absolutely, I think, absolutely critical. We've, thank God, here in Kentucky, our governor had been probably one of the most aggressive in the country with social distancing. And we're nothing like some of the other major hotspots. That's wonderful. But on the other hand, this is like a slow motion disaster. Because we were planning for the potential tsunami wave coming, hoping that it wouldn't, but at the same time, you're having to prepare everybody for that eventuality. So articulating that plan, how we were going to respond, and making sure everybody was on the same page with this, that was also really important. The other thing is trying to take some control of the messaging. What I was facing, at least initially, and what I'm going to do is just tell you this from our perspective, was I was having individual faculty members, 50 of them each day, sending 10 emails each about something related to this. So the volume was deafening, and the volume of misinformation to try to correct afterwards was deafening. So what I did was, firstly, is tell everybody not to do that. I mean, I was very, very clear that if you find something that you think would be of general interest, send it to me. I'll curate it and package this so that one communication, at least from the department standpoint, is going out every day. And after a few days, like neurologists, they're sort of like free thinking, they're going to do what they want to do anyway. But we were able to put the clamp down. So you're talking about the messaging, doing it once a week more frequently. I put out a departmental email every day, and it goes to all of our faculty, all of our residents, all of our APPs, and then it goes out to all of our staff. And different folks have different things that they want to look at. They don't have to look at the whole thing each day, but then at least there's one codified message. So I think developing that strategy for us was particularly important. And as you know, there's been a flood of papers every day now. I've reviewed many of them, or some of them at any rate, and the quality of many of them is such that in the normal times, they'd never see the light of day. A lot of these are still being published, and I've tried to sort through those to include the ones that I think that are that are relevant. And as was also mentioned by a couple of folks, the rumors that can take off are really reality can be bad enough, but the rumors can be even worse. So this single daily email, like I said, with curated need-to-know information. We can include things about personal wellness, COVID-specific local updates, neurology relevant publications, neurology relevant policies and procedures, things that we've done in the department related to care, and then also links to resources for folks who do want to take advantage of that. Childcare is really important. Folks who are in the hospital and don't want to go back to a home where they may have an elderly relative or an immunosuppressed relative, having access to all that information, I think, is really helpful, and also shows that we really are thinking about them. Okay, next one. Here we go. Engaging relevant leaders in the department and in the faculty are also really important. It was also mentioned department administrators are really absolutely key. We're pivoting on a dime from usual practice to very, very unusual practice. Before we put that out, anything, I do send it up the chain of command. As David had mentioned, you don't want to be seen as being rogue. If you do that, then you lose all of the leverage you have with the administration. So before we develop a policy and I put it in print and I send it out to everybody, I do let the, we have operations command, incidents command, all these commanders now. I send it to the commanders and I just get their feedback first. We do, when we developed our overall plan, I had separate review sessions that I did with all of the faculty first, then all of our residents, then all of our APPs, and then all of our support staff. I wanted to make sure that everybody understood where things were, why they were being done, what the thought process was in that. If reality changes those, we're gonna tweak them, but that way they, I think, get the understand that there is leadership, we are planning, and that we've thought this through as carefully as we can. Okay, next one. Here we go. Again, the institutional response is also one that's really important. Yes, we're a department, but we're a department in the overall institution, and the plans that we make have to be aligned with the overall healthcare unit plans. So we've extended our scope of care, as was mentioned in our neurologic intensive care unit. We're taking care of the types of patients that we never would have. We had a fitness for duty assessment. You know, normally as a chair, I don't know individuals' healthcare issues. I don't know how old they are. I'm not supposed to know most of that stuff unless it affects their work. In this case, I had to write all of our faculty and all of our residents about any medical issues they may have so that we could plan appropriately, about any issues at home that we should know about that might impact their fitness to for duty. The kind of things that, again, in normal times you would never dream of asking about. So yes, I now know things I wish I didn't know, but as we were having to deploy people or think about how to deploy people and plan ahead, knowing those things, I think was really important. And again, there are some, I think the faculty and the residents and the staff all really appreciate that we're considering their personal lives and their personal problems as we're making these decisions. These folks did not sign up to go to the front lines in Afghanistan, right? These are medical students, physicians, residents, and support staff. So we're asking them to go well beyond anything they thought they'd ever be doing. The PPE use and strategy, that was also really critical. Everybody wanted N95 masks to wear all the time, right? That couldn't happen. We don't have them. They don't exist. And how are we going to rationally use that? That was the whole idea that why elective surgery and elective procedures went away, is because they would consume PPEs that we would need to protect people who are being primarily exposed. So again, once we went through the explanations and they understood, that was okay. Okay, next one. And then, yeah, two-way communication. Communication is a two-way process, and having multiple channels, multiple ways of hearing what people are thinking, being able to respond to it. I think that's incredibly important. You know, they know that I'm always there. My door's always open. Well, that some people, like, they don't want to know where it's coming from. I have a suggestion box that people can put things in the old-fashioned way. They can write on it and not sign it. But they're keeping those multiple channels open, always responding. It shouldn't be a dead letter office. If somebody comes with whatever the issue is, no matter, you know, we as chairs, we all face this, right? You're sitting there sometimes and you're saying, really? Really? But responding, responding to all of those issues in a cogent way, still articulating the main message, I think is really important. Keeping all of your leaders informed and engaged, and again, not forgetting about the departmental staff, because without them, nothing happens, right? They're the ones that are doing switching on the dime and setting up telehealth. They're the ones that are communicating with patients. They're incredibly important, and they have to be thought of as part of the team, and they need to feel that they're part of the team. So this is like, I guess, chair 101, but it's now magnified up to an exponential level. Having that message, articulating it, being consistent, and making people feel that you care about them, and showing that leadership, that there's somebody at the rudder here, and this is not just things being done to people. All of that, I think, is all real important.
Thank you, Larry, and some great points. I'm taking some notes here as well because, my own department, I think we've done well with residents and faculty, and I'm assuming the staff, my vice chair for administration is taking care of the staff, but that's a great point you made about staff as well. So we have a couple questions that have been written in, and then I have a couple that we have a little time to handle questions. Somebody has written in about, engaging the neuro trainees. We talked about deployment or redeployment, and it sounds like at Mount Sinai that definitely happened for both neuro faculty and fellows. And then I think Richard say that the residents, because the staff was already so busy with COVID-19, that residents weren't redeployed. But I guess the question is, when you have had to, if you've had to redeploy residents, how has that worked? Has it been voluntary? Have you had to assign them? What if they don't want to do it? How have you dealt with that? Richard?
Well, I can tell you our experience because we had to do this quickly because we have Washington Heights, where Columbia University is a relative hotspot within the city. And we, of course, anybody over 60 was put on the back burner, not prioritized, and people under 60 were informed that they could be redeployed, and that if there was a reason that they didn't want to do that, they should first write me, and then I would pass it on to the dean's office. To be quite honest, there was one person who didn't want to tell everybody she was pregnant, but she is, and so she didn't want to go, and that was fine. And that was really about it. Everybody else went, our fellows, our faculty, and the reason our residents didn't get redeployed is because we became a COVID intensive care unit. So there was no place for them to go because they had to stay there and take care of the patients.
So, one point you raised, this one about fitness of duty, and I think Larry raised it, and you indicated that it went through the chair. At our place, the way it worked was they had to directly communicate with faculty affairs. And so I was out of the loop, so I didn't learn about certain, health issues. But they went right to faculty affairs, then faculty affairs would pull them out of deployment. But what about you, Steve? Residents?
So we redeployed our residents. We asked our residents, would they want to go to the medical ICU? And some of them said, yes, we would. Would you want to go to a medical floor with COVID patients? And some of them said yes. And what we did, therefore, was switch the schedules of everybody. It was important to have a bullpen. We had about a third of our residents. We have a total of 45. We had about a third of them sitting at home doing pursuit or something like that. That became invaluable. 1/3 of our residents, 15 of our residents, became either COVID positive or had COVID symptoms. And we made it through because we had a bullpen. We asked the neurointensivists, who now, like Richard, were leading teams with medical doctors, who were our best residents for critical care. And they told us, and it just happened that the residents that we thought were good in critical care wanted to do critical care. Many of them going into stroke or neurointensive care, for instance. So it worked well as a team. And then some people were assigned to call the patients on the outpatient side. And that's what they wanted to do.
So what if a resident or fellow, we'll leave a faculty out of it for a moment, really were so anxious and concerned about their own health, they didn't want to do it. what strategies would you use if you needed to convince them?
Well, we talked to them and we tried to accommodate those fears, which were very real, and put them on rotations that were neurology rotations.
Okay.
Neurology dried up. Dramatic drop in volume in the hospital during this period of time for neurology. So we just were able to manage it.
Right. I want to go to PPE for a second. You gave a great point about, other supply chains. Did you ever worry, though, when you get these supply chains with these emails that come from you don't know where, that the quality of what you were receiving would not be adequate? We were worried. And so I had to direct them to a central place where they could be vetted to decide if the quality was appropriate.
Yeah, that good question about
Let's see. Oh, Larry, go ahead, Larry.
No, go ahead, Steve.
Go ahead, Steve.
A good question about that. For instance, we got 80 gowns from our own epilepsy office, and we knew that they were consistent. The gowns we got from the medical students were likewise consistent with what was in the hospital.
Okay. What about
this is Barbara. Oh.
Yep, go ahead, Barbara. Sorry.
Oh, I wanted to go back to the prior comment. I think I had muted myself. The prior question about. I think the other thing is that think about this as a process for everybody. And when this all started, we were all kind of entering it, going, like what's really, because there was a lot changing in New York City, and I think that when they started putting in place the restrictions and in terms of places of business being closed and all that, I mean, it happened kind of quickly. And so for people, I think that it was important to give people some time to have a chance to digest what was going on and really think about, like, what was their role in this, and what were they, what were they going to become comfortable doing. Everybody obviously needed information about the donning and doffing, as we call it, of the availability of PPE, just information. Like if you're going to be on a medicine team, people wanted to have the information to study so they could at least feel, like they were comfortable with that. And then I think, but I think it's important to not just accept somebody's first reaction as necessarily where they were, because I think it was a process for most people. Our residents were amazing, because I think initially they were like, well, like, why would we be doing that? We're studying neurology. And our, we spoke with them. Our residency director was fabulous, and she met with them. And really, though, on their own, over less than a week, the whole group became, we're totally committed to this. We want to go where there's the most need. Several of them wanted to go to Elmhurst, which had a rough period. If any of you watched the news, and they were like, no, we want to be there. We want to help these patients. And so I think I would just add that there is an element of both understanding what people's personal situations are, and I agree with Larry about, I wasn't expecting to know about medical issues and things, but on the other hand, that's just part of what was going on here, and trying to be both fair for everybody and also respond to people's anxiety by trying to provide information and letting them, have a chance to think it over and talk among themselves.
Right.
And again, I would just say every single person who has been deployed has said they're really glad they did it. They're glad to be doing it. They feel like they make a difference, and that they were able to work through, if they had anxiety, to work through that. Many other people were like, I can't wait to get out and be participating in this mission.
Thanks, Barbara. I mean, there was another question. I know we're getting late. I'm going to go a couple minutes over, but I'm sorry about that. But then we'll try to end. I know, Steve, you gave me an example, but any residents that went out sick and then were severely ill, or faculty where there could have been a death or severe illness? I know, Steve, you were telling me about something. How would one deal with that?
Okay, that is a terrible. Fortunately, all of our residents did incredibly well. We did lose a faculty member a senior faculty member who died from COVID. We have another one who's critically ill right now. It really, really added to the trauma of this. And you know, counseling has been important for all of us. And that's why I emphasize that manual. That's why there are daily group sessions and individual sessions available. Yes, it's been incredibly difficult, and there's been crying. So we try to laugh, we try to, you know, we have our emotion, and we try to think as much as we can.
Larry, did you have your hand up there?
Yeah, no, I was just going to say, this is never good. The dean just called an emergency meeting at 6. So,
So we're almost wrapping up here. So the communication has been critical also that David and Larry emphasized in whatever way, and do it often. And I think that's critical. I mean, I'm not someone who tells jokes at the humor part. You know, I don't think I sent around as much humor. I tried one humor at a meeting that somebody gave me a video and it didn't go over as well. So, but I think it is good if you can do that. So again, I appreciate everybody's comments. We will share the slides with our audience. We got to most of the questions. If there are other questions, I'm sure we can handle them. And then also, I think Steve Galetta, you will share the psychosocial support you mentioned. I want to thank, first of all, the group today, especially the New Yorkers that are with us, Richard, Stephen, Barbara, thank you very much. And David and Larry, I know Darren had to run off. Before you leave, if we can go to, there's a quick poll for anybody who's been attending. If we can go to the next slide and somebody can bring up the poll sort of to evaluate how things go. So did the webinar meet your expectations? Yes or no, or kind of? And then would you be interested in attending another one? And as I mentioned in the beginning, please let Sue or Claire or any of us know if there are topics you want to hold, you want us to cover. We feel like we need something for the academic business administrators out there. And we do have a couple academic business administrators who have some ideas about keeping a virtual workforce and staff going. So we may be thinking about another one and gear some of the topics for that as well. Again, I appreciate all our panelists. Stay well. It's not easy for those who haven't hit it yet, but we appreciate the New Yorkers being here and telling us what to look forward to and how best to prepare. And David, of course, you from Boston as well. Thank you very much.